We'll get started. Am I recording? Okay, perfect. Oopsie daisies. All right, so the first slideshow, again, stereotypical structure. We're going to start with the new material with a focus on cancer to get started. Lovely topic on this Wednesday evening. Here's a list of terms to know. Again, you know how you study best at this point in this course, but my suggestion for terms and definitions is Quizlet or just flashcards, handwritten. Definitely just knowing these will help you understand the pathophysiology, but will also help provide a basis of understanding for the pharmacology as well. Um, Sorry, I have to close this. Okay, perfect. So with cancer, or with the body in general, you have your normal body cells. Um, these cells present well differentiated. They have a very clear appearance and a specific role that they play. And they reproduce for a purpose and they stop reproducing or they kind of die off when that purpose is met. We talked about it a lot more like in microbiome, but there are all those ways that cells kind of self-destruct when they are no longer needed, and that's completely healthy. With malignant cells, though, these are undifferentiated and uncontrolled. They serve no physiological purpose, and they like to steal nutrients and blood supply from your normal healthy tissue, which is oftentimes what creates a lot of the problem with tumors. Additionally, malignant cells can break off from where they begin, and they can kind of circulate via the bloodstream, via the lymphatic system, and metastasize. Tumors then can be benign or malignant as well. Benign tumors are your non-cancerous tumors. The cells that create a benign tumor look normal. They're going to be encapsulated, well differentiated. They might still serve a purpose. They're going to be super localized and without metastasis. So these are tumors that are not going to be spreading throughout your body. A benign tumor is not a cancer. A malignant tumor then is cancerous. The cells that create a malignant tumor do not resemble normal cells. So you're going to see that uncontrolled reproduction, poor purpose, stealing nutrients from normal cells, etc. And malignant tumors do have the capacity to invade tissue and metastasize throughout the body as well. Carcinogenesis is the process of cells becoming cancerous. Cancer doesn't just appear out of nowhere. It is a three-step process. It starts with initiation, which is basically just the exposure to carcinogens that are capable of causing DNA cellular changes. Um, Carcinogens are everywhere. We all know that. I've been to California and literally every building you walk into just has signs. It's like, stuff in this establishment can cause cancer. Like, yes, I know. Um, so, yep, initiation is just that initial cellular alteration on the DNA level. Promotion is next. This is when those affected cells from a carcinogen start replicating and expanding. So now you're getting abnormal cells that are spreading. Um, Repeated exposure to carcinogens is going to encourage and speed up this process. But the good thing here is that it is reversible at this promotion stage. So you can kind of, if you limit your exposure to carcinogens, your cells can kind of revert back. The last process of carcinogenesis is progression. This is when there's an increased malignant behavior. So these cells are starting to act more like malignant cells, abnormal cells. They're starting to kind of just develop in an uncontrolled manner. And this is when your body kind of undergoes a process called angiogenesis. So your body's actually going to create new blood cells to feed these altered, potentially malignant cells, which is counterintuitive, but your body doesn't really understand fully what's happening because those cells are not like yet recognized as abnormal at this point. Again, carcinogens, they're everywhere. We've all probably heard that term. Most of what we eat, most of what we consume, our entire environment, unfortunately, is a carcinogen. I would just generally know some examples of what physical agents could look like. So, radiation, UV rays from the sun versus like those chemical agents versus genetics. There could be some questions about being able to differentiate those causes. For prevention, you guys have learned prevention probably multiple times at this point, and you will continue to do so. Primary prevention, you are doing things way early on. You're giving certain vaccines. For example, the HPV vaccine can help prevent cancer. Specifically, I think cervical cancer is a big one. Um, Avoiding known carcinogens. You know smoking's a carcinogen, so hey, let's not do that. And a healthy diet. Secondary prevention then is all the screening that we do. So think mammograms, think like colon cancer, colonoscopies. When men they have to get their prostate checked, that's all those type of secondary prevention. And then tertiary prevention, the patient typically already has or has had cancer. So you're either treating the cancer, trying to prevent an increased severity, but also trying to prevent reoccurrence or relapse if the patient is, like the word, in remission. That's the word I'm looking for. Cancer, I'm sure, isn't a surprise to everyone that the manifestations and the symptoms will vary drastically depending on what type of cancer, where the cancer is, and how kind of advanced the cancer is. And a lot of cancers can go asymptomatic for a long time. Those symptoms typically appear when that malignant tumor is large enough to, supply that blood or interfere with blood supply, change physiologic organ function, etc. But across the board, some pretty common clinical manifestations are going to be weight loss, anorexia, cachexia, poor healing, altered organ function. You can have a lot of like bleeding issues and anemia-like symptoms, pain, and increased infections, which would be related to immunosuppression. I know you guys talk about this in adult too, so I'm not going to go too much into it. But you do need to understand the difference between these treatment goals, between cure, control, and palliation. Cure, we're eradicating the disease. Pretty simple. Controlling is we're trying to control the disease enough to prolong survival, to contain that malignant growth, to improve quality of life. And then palliation really is not focused on eliminating or controlling the cancer, but rather relieving symptoms associated and improving quality of life for whatever time that patient does have left. Surgery, there are a bunch of different types. Diagnostic surgery is primarily biopsy. You do have to biopsy tumor or cells to be able to come to a cancer diagnosis. There's surgery meant for treatment, which is fully removing tumors or removing to the best of your ability. Salvaging surgery, this is surgery to treat a recurrence. Prophylactic, this one always interests me. It's the removal of a tissue at risk for developing cancer. With prophylactic surgery, this patient does not have cancer, but maybe all of their women in their family have had breast cancer and they test positive for BRCA and they're really scared of getting breast cancer, which is totally valid. They can undergo like a prophylactic mastectomy and get their breast tissue removed. That would be prophylactic surgery. And then lastly is reconstructive. Another best example here is post-mastectomy. Some women will have like reconstructive artificial breasts surgically done for the sole purpose of like function and cosmetics as well. Radiation. Radiation can be curative, but I feel like a lot of the times it's used to reduce tumor size before surgical removal, just to kind of make that surgery a little bit more feasible. Um, the cells that divide the most frequently are the most susceptible to radiation. So you're going to want specifically tumors that are replicating fast. Radiation will work better. You can have external radiation, which is I think what most of us think of when we talk about radiation for cancer, but you can also have internal radiation, which that picture that they show you in adult two, the brachytherapy, that threw me for a loop. That is crazy stuff. But with internal radiation, you're placing a radioactive source basically in the body at the cancer site. Um, Adverse effects of radiation are ideally localized to the specific area being treated. You can see a lot of skin issues, that radiodermatitis, bone marrow suppression. So think about the anemias and the immunosuppression that that could cause. And then also systemic things like fatigue, anorexia, malaise, which is just the general not feeling well. Um, you really need to protect yourself and the patient and their visitors from the effects of radiation. If you do not need to be exposed to radiation, you should not be. If they're undergoing brachytherapy, they need to be in a private room. Visitors need to maintain at least 6 feet of distance, and nobody pregnant, visitors or staff, can enter the room for the safety of the fetus at that point. Chemotherapy then works to kill cells by interfering with the replication process specifically. It is also the most effective against rapidly dividing cells, regardless of their status as normal or malignant. So that is why chemotherapy has so many side effects, because any cell that is rapidly dividing is going to be killed and harmed by chemotherapy, even if they're good for you. The most common example is hair. Your hair is not cancerous, but chemotherapy is going to cause you to lose your hair because your hair follicles involve rapidly dividing cells. So chemo attacks those. You do require repeated doses because each dose only kills X amount of those cancer cells. And it is administered in combination to reach maximum effectiveness while minimizing damage to the healthy cells. That's also administered with a recovery time, certain cycles of chemo to allow for the body to not only heal from chemotherapy because it is so, violent and aggressive against the body, but also to allow for those healthy cells that were killed to kind of be replaced and regenerate. One of my friends, literally 23 years old, crazy, has had breast cancer and she had like 6 chemotherapy cycles. So she would go in and do chemo all day and then have like 2 weeks off and then go in and do it again. And that's just that cyclical nature. She's okay. She's in remission, so that's good. Complications, the big one is immunosuppression. These patients are at a huge, huge, huge risk for infection. So they need to be on those neutropenic precautions. Um, and in addition, they can also have thrombocytopenia and anemia, so just kind of pancytopenia across the board, just low counts of a lot of different things, white blood cells, platelets, etc. Nausea, vomiting is a huge one, mucositis, then bleeding and fatigue. It's not a fun drug to deal with. Which of the following is an example of secondary cancer prevention? Yep, that one's going to be D. A and B are primary and C is tertiary. Which of the following statements is not true about radiation? Awesome. Yep, that one is going to be C. Not always, sometimes. If no one's ever told you, if you see always on a nursing exam, it's probably not the right answer. Very rarely is the answer actually always XYZ. Which of the following is an example of prophylactic surgery? I'm not gonna lie, I made these questions last semester. I'm trying to look at them. Perfect. Yep. That one's gonna be C. Good job. All right. That brings us to the cancer medications. I would recommend understanding this kind of, I want to say like condensed version of the cell cycle, just knowing, you know, S is DNA synthesis and that most mutations do occur here. I feel like that's important. But just knowing S, G2, M, G1, just a general understanding of those, because you do need to know where certain medications take effect. So alkylating agents, these include cyclophosphamide, nitrosoureas, platinum agents, and your triazine compounds. These are cell cycle nonspecific. So all those cycles or those stages in the cell cycle that I just mentioned, it doesn't matter. These are going to work in all phases of the cell cycle. The prototype is cyclophosphamide. It is the most commonly used medication in this kind of drug class. Definitely know this adverse effect. It's hemorrhagic cystitis, um, which you can kind of use like root words to figure out what that is. Hemorrhagic, bleeding, cyst is bladder, itis, inflammation. So you can have major issues with your bladder, your bleeding in your urinary tract, etc. So you can see hematuria, urosepsis, so it can progress to sepsis, and you need to increase the patient's fluid intake. That is a huge adverse effect to know. Um, if your patient, is on chemotherapy and they're so nauseous because of these side effects that they can't get their fluid intake, that's something that you can then advocate for and say, I know my patient's taking this medication and they're at risk for this. Maybe I need to request an order for additional IV fluids, so that we can bump up their fluid intake to prevent that adverse effect. That's kind of an example of how that could come into practice. Another alkylating agent would be your carmustine and lomustine. These are nitrosoureas, that's their drug class. The most important thing to know about these is that they are highly lipid soluble, so they do have the capacity to cross that blood-brain barrier and enter the brain and cerebral spinal fluid. So these two alkylating agents are explicitly effective for those brain type cancers. I would definitely know that. Carboplatin, it's a platinum agent prototype. Not much to say there. Dacarbazine is the most commonly used triazine compound as well. Anti-tumor antibiotics. My friend had a fun way to remember this one, I'm pretty sure. Daunorubicin, there are two. The first one is daunorubicin. It is active in all elements of the cell cycle. It has a similar effect as the alkylating agents. Um, know these adverse effects. I would recommend that. Daunorubicin is cardiotoxic, and it also can induce bone marrow toxicity. Bleomycin is another one of the antibiotics, but the adverse effect you need to know for it is pulmonary toxicity. This is kind of a dumb way to remember it, but when I took the course, my friend remembered that bleomycin was pulmonary because he would go bleh, like bleomycin, bleh, and it made him think of lungs. I don't know. If it helps, it helps. But that's what my friend always did. The next drug category are antimetabolites. These work explicitly in the S phase of the cell cycle. There are two different types. You have methotrexate. This is a folate antagonist. So what it's going to do is it's going to antagonize or work against the action of folate. And folate's actually required for cell division and DNA synthesis. So if you inhibit that folate action, you're going to inhibit cell division and DNA synthesis as well. Fluorouracil, I found this one kind of cool. Um, Uracil, if you remember, is a component of RNA. I like to think of fluorouracil kind of as a fake uracil component. So it's going to implement itself into RNA strands where that uracil should be, and it's going to kind of halt that whole RNA transcription process, because now there's a little fake uracil in there, so it can no longer grow effectively according to its coding. Plant alkaloids, there are taxanes and vinca alkaloids. The taxanes work in the G2 and M phases. Um, with these taxanes, allergic reactions are pretty common, so you will most likely need to pre-medicate your patient with something like Benadryl. I would keep that in mind. There's an example taxane on there for you. Vinca alkaloids, the main one is vincristine sulfate. Um, excuse me. As an adverse effect, you can develop neuropathies, especially like peripheral neuropathies. And to take that one step farther, if a patient has an OD or, you know, excessive prolonged use of increased in sulfate, they can have paralysis. So think about that peripheral neuropathy getting too far, and then you get some level of paralysis. Cytoprotectants, we've talked about these in the last unit, actually. These work to reduce the adverse effects of cytotoxic drugs like chemotherapy, um, because chemotherapy will cause that drastic pancytopenia and immunosuppression. So you would give that epoetin alpha to treat anemia and raise those red blood cells. Remember that epoetin alpha has an adverse effect of hypertension. Filgrastim is the medication that'll treat neutropenia, so it's going to heighten your white blood cells in patients who are leukopenic related to chemotherapy. Perfect. What part of the cell cycle do alkylating agents work in? Yep, that one is cell cycle non-specific. Good job. Sorry, guys. What is an adverse effect of the anti-tumor antibiotic bleomycin? You guys are going to be taking your exam and you're just going to hear me making bliff noises over the Zoom screen. Yeah, that one's pulmonary toxicity. Good job. A and C are those daunorubicin anti-tumor antibiotic adverse effects. That's a mouthful. What part of the cell cycle do anti-metabolites work in? That is gnarly. Gross. Yep, that'll be B. Good job. Your patient is receiving cyclophosphamide for cancer treatment while admitted. Which of the following findings is the most concerning regarding this medication? Yeah, perfect. That is A. That's a sign of that hemorrhagic cystitis. B, C, and D are technically adverse effects, especially B and C, and you would want to consider treating them or, implementing precautions, but those are all expected. So the most concerning would be A. So you guys got that. Okay, let's see how we're doing on time. Perfect. That is what I have on cancer. So we'll go ahead and move to HIV and AIDS. I think this is the shortest bit of information on this slideshow. Again, some terms to know, understanding the difference between things like PrEP and PEP, which we'll talk about, um, the fact that HIV is a retrovirus, those types of things. Like I said, the virus is a retrovirus, so it carries its gene material in RNA. It works by targeting the CD4 receptors on T cells. And if HIV progresses or is untreated, it can cause AIDS, which is acquired immunodeficiency syndrome. That is primarily made up of the progressive immune system destruction related to the virus destroying these T cells. And HIV is transmitted via bodily fluids like semen, amniotic fluid, and blood. So major things like unprotected sex, sharing needles, etc. Put a patient at risk for this. Also, as nurses, we are at a higher risk for something like HIV because of accidental needle sticks. So take your time in capping needles, move slowly, because the protocol for dealing with a potential needle stick to make sure you didn't get HIV is it's not fun. Also, even worse if you actually get HIV. So just be careful. Um, HIV progresses in stages. Stage 0 is when the viral load is very high, so the patient's contagious, and they might have minor signs and symptoms of a viral illness. Just your typical run-of-the-mill, what I have right now. Just sick. Stage 1 is the viral set point. Your body kind of reaches equilibrium between that HIV infection and immune response. And the patient is largely going to feel okay, but they might have mild symptoms here and there. Stage 2 is when your T cell count kind of plummets, that HIV has done some damage. And stage 3 is the most progressed when you can develop AIDS and the patient is at an increased risk for those opportunistic infections because the person is immunocompromised at this point. ART is antiretroviral therapy, which is the treatment of HIV. Um, you typically treat with multiple drugs from different classes to reduce drug resistance, but also to attack the virus from as many angles as possible. It is important to acknowledge that HIV does not have a cure. HIV, none of these meds that we're going to talk about are curative. However, they can reduce the viral load to close to zero. The goal is to lower that viral load as much as possible. Um, Antiretroviral therapy allows the patient to live symptom-free, reduces the risk of transmission from mothers to babies, better prevention in general, and it has proven that with ART implemented, there's been a steady decline in the death rate and progression to AIDS. The major downside with ART is that there are a lot of pretty serious adverse effects, and the success of the treatment depends heavily on client adherence. These medications can cause liver toxicity, kidney toxicity, and cardiovascular disease. And a lot of the times, these medications have really not ideal schedules, and the adverse effects are sometimes not fun. So patients might not, they might not take their meds like they're supposed to, um, because of those different factors. So it can be really, really hard to, kind of get patient populations to adhere to that regimen. Generally, we're going to monitor that CD4 count every 3 to 12 months to evaluate effectiveness, see how well the meds are working, see how med adherent the patient's being. And if a patient abruptly stops ART, it would result in rapid rebound HIV replication, putting their body at risk for major CD4 destruction and potentially the development of AIDS. PrEP is pre-exposure prophylaxis. So these are taken by people who do not have HIV. These are preventative medications taken by those who are in high risk groups to prevent HIV infection. Um, there's a commercial that I see on like Hulu maybe or Netflix, I don't know, all the time that's talking about like once daily PrEP. That's preventative prophylaxis. PEP then is post-exposure prophylaxis. So, the patient, say me, I'm a nurse, say I get a needle stick. I don't have HIV yet, but I could. So this is you've been exposed, but you don't have it yet. That's why it's still referred to as prophylaxis. The CDC recommends starting treatment with more than 3 antivirals within that first 72 hours of exposure. So that's pretty fast, pretty intensive. But again, the alternative is HIV, and nobody wants that. When looking at the mother-baby scenario, I don't think we talk about this too much in maternal infant. Correct me if I'm wrong. But the goal in this treatment is to lower the mother's viral load to hopefully protect the newborn from acquiring it. If a mom is HIV positive, you're going to start ART as early in pregnancy as possible. And during labor itself, you're going to run a continuous infusion of NRTI, which is zidovudine, which we'll talk about in a minute, because this drug is capable of crossing the placenta and providing fetal protection. If the mother does receive treatment during pregnancy, once the baby's born, the baby's going to receive 4 weeks of prophylactic therapy with just zidovudine. So that's if the mom knows she has HIV and she adheres to treatment during pregnancy. If the mother doesn't know she has HIV or hasn't been adhering to treatment, that newborn is going to be treated with up to 6 weeks of prophylactic therapy with multiple drugs. So it's a lot more intensive. Um, that newborn would have a definitive answer if they have HIV by about 2 months of age as well. So you can't test it within the first few hours after birth, but by 2 months of age, you'll know if that baby acquired HIV from their mom or not. Um, the other big one, I don't think I mentioned it. Um, Before you give babies any kind of needle stick, you need to bathe them. Because you do not want to have an HIV positive mother give birth to a baby and then you heel stick them, because that could introduce the HIV into their system. So you need to give them a thorough bath and then stick them, just so you don't introduce HIV. Some of the drugs, I like to think that these drugs are pretty straightforward. If anything, they just have kind of crazy names. The NNRT is efavirenz. This works by preventing reverse transcriptase. I wouldn't freak out too much about knowing the specific actions here. More so these adverse effects of liver toxicity, central nervous system impacts, as well as increased liver enzymes. So big thing is liver and CNS. And then you have NRTIs. This is zidovudine. We talked about this one a few times. Adverse effects are liver toxicity, blood disorders, bone marrow suppression, and lactic acidosis. So those are all pretty serious, and you need to be monitoring those LFTs, CBCs for those blood counts, um, symptoms of lactic acidosis, etc. And zidovudine does have kind of a intense administration schedule because it does need to be taken around the clock to maintain a therapeutic blood level. A protease inhibitor does exactly that. It inhibits protease, which is an enzyme required for the formation of a virion, which is part of that virus cell replication. The prototype is saquinavir mesylate, and its adverse effects are cardiac arrhythmias, CNS abnormalities, pancytopenia, and elevated liver enzymes. So you're seeing some patterns. We're talking about some pretty serious side effects. We're talking about liver a lot, cardiac a lot, blood, bone marrow a lot, CNS in there as well, just to recognize some patterns. And then you have integral strand inhibitors. These are used in combination with NRTIs because they aren't the most effective by themselves. The prototype is raltegravir, and the benefit is that these have significantly fewer adverse effects. Again, the downside is maybe they're not the most effective independently, but it does have fewer side effects, so that's something to note. I think that's everything on HIV. What does HIV target? Yes, that'll be A. What is the treatment regimen for a newborn baby whose mother is HIV positive and did not receive treatment during pregnancy? Last semester, I can't lie, like half of people got this one wrong, so I'm already very impressed. Yeah, that's going to be C. The mother was untreated, so we're doing the most. 6 weeks of therapy with multiple different antivirals. When would someone follow PEP protocol? Awesome, guys. Yep, that one is D. This is post-exposure prophylaxis. Um, well, we need to know which medications are for treatment-experienced patients. Ooh. I don't think that was on the blueprint, to be completely honest, because if it was on the blueprint, it would have been on the slideshow. Um, I personally don't recall being asked something about that, so I don't know. I don't have a better answer. I'm sorry. I don't recall learning too much about that or being tested on it. But it couldn't hurt to glance over it. Yeah, no problem. Sorry. I wish I had a better answer. That takes us to bleeding disorders and anticoags. Um, these can be kind of tricky because they are kind of similar again. Um, but a lot of it I feel like you guys will have a good understanding of because it's drugs you've heard before, and it kind of goes in line with that hemostasis and anemia unit that we just had. Terms to know, hemostasis, just kind of that process. But again, we talked about that last unit. And then also the difference between an anticoag and an antiplatelet. Functions to know that platelets are present to form clots and stop bleeding. Plasmin is present to digest fibrin to remove a clot. Vitamin K is a required vitamin for the liver to develop clotting enzymes. And then factor X and fibrinogen are on there as well. Thrombocytopenia, we've talked about this in different units, is just a low platelet count. So we can, think that platelets are responsible for clotting and bleeding. Um, so if we have low platelets, the patient is going to present with bleeding, which could present with bleeding gums, that like mucosal bleeding, heavier periods. If they do have a wound, they might bleed more excessively and have a harder time clotting. They can also have petechiae, which are those like little red dots on your skin. Um, Thrombocytopenia can be caused by decreased production from the bone marrow, so chemo would be a big cause of that. Increased destruction of platelets, which there are some different causes of, or increased consumption of those platelets, like you're using them up too much. And really, the treatment here is to treat the cause and to stop and prevent bleeding. So not much you can do there. You can administer platelets as well, but again, mainly treating the cause. Um, okay, immune thrombocytopenia purpura. This is similar to just thrombocytopenia, but in these patients, there are specific antiplatelet antibodies that bind to your normal healthy platelets and mark for destruction. So this is an autoimmune disorder where your body is mistaking healthy platelets for invaders. Um, ITP, which is the shorthand for this, can be considered dry or wet. I don't really understand the names, to be completely honest, But dry ITP presents with bruising, petechiae. It's typically less severe and the patient does have better outcomes. Whereas wet ITP involves more serious bleeding, specifically in the GI tract, so internal bleeding, and there's an increased risk for life-threatening bleeding. Diagnosis is primarily a diagnosis of exclusion, and treatment is going to be based on the severity of bleeding. I would argue the most important thing to know about ITP is that platelets, they're not going to be effective. So with just normal thrombocytopenia, if you have a low platelet count, sure, you're going to run a bag of platelets, you're going to bring their platelet count up. But if a patient has ITP, they have enough platelets. Their body just doesn't like those platelets and it's going to destroy them. So what happens is if you give your patient a platelet transfusion who has ITP, that's great and all. You might bring up their platelet count for a minute, but then that autoimmune system is still going to kick in. It's still going to recognize those platelets as bad guys, and it's still going to destroy them all. So platelet transfusions really aren't going to be effective. So your best bet is to help educate the patient on how to prevent bleeding, signs and symptoms of concerning bleeds like GI bleeds, and then really helping treat those bleeds if they do occur. Platelet defects. With these platelets, if you run a CBC, their platelets might appear normal. They're going to have a normal count between that 150 to 400K. But those platelets are defective to some degree, so they're just not functioning 100% correctly. Aspirin can cause a platelet defect. Same with NSAIDs. I would know that the aspirin effect can last up to 10 days with that reduced platelet aggregation, and the NSAIDs can go up to 4 days. Um, just knowing that, maybe a week after you stop aspirin, you could still have reduced platelet aggregation could be important for things like surgical procedures. Um, Clinical manifestations would be bleeding. Again, we're talking impaired clotting. Treatment, you can stop the medication that's causing it, like aspirin or NSAIDs, or you can run a platelet transfusion. Platelet defects are responsive to platelet transfusions because you're transfusing healthy platelets that are not defected. And again, teach to avoid meds that would contribute to bleeding. Primarily those NSAIDs is a big one. Hemophilia A, this is a genetic defect in factor VIII. It's more common than hemophilia B. Um, Really, I would just know the treatment. You can actually administer factor VIII concentrates, which would specifically be administered during active bleeding. Because again, these patients, their factor VIII is not effective. If they're bleeding, they're going to need some outside support. So you can administer that factor VIII. Over time, if your patient has hemophilia A and they go through, multiple periods of bleeding where they need treatment, these patients can develop antibodies. Um, and if that's the case, you would also consequently administer steroids to act as immunosuppressant to control those antibodies to allow concentrates to do their thing because there aren't really other better treatments for hemophilia A. So you basically have to find a way to make the body tolerate that factor VIII concentrate. That rhymed. Von Willebrand disease, VWD, is a genetic deficiency in VWF, which is a required factor for factor VIII activation. So in this one, factor VIII isn't deficient of itself, but the factor that allows the body to create factor VIII is deficient. So you can still have that deficiency. It is the most common inherited bleeding disorder, and the main sign is bleeding in mucous membranes. Treatment, you can actually administer that von Willebrand factor or just those factor VIII reconstitutions when that bleeding occurs or preventatively prior to a surgical procedure as well. DIC, this is a fun one. We just learned all this again in Adult 3. DIC confused me a lot in Patho 2, I can't even lie. Because I was like, how in the world are you bleeding and clotting at the same time? Like this just doesn't make sense to me. So if you're more visual, I did link a video on there that could help you in your studying. But DIC is an inflammatory process generated by an underlying disease. Things like major infection, a septic response, major traumas, or shocks. I think the most common cause is septic shock. Um, so at once, your body's kind of in overdrive. Its compensatory mechanisms are not doing too hot. So you have extreme clotting that uses up all of your good clotting ability, essentially, rapid clot dissolution, and pretty intense bleeding because you pretty much ran through all of your clotting factors. So now you're bleeding. It is going to be diagnosed with a progressive drop in platelet count, um, prolonged PT, APT, APTT, and thrombin. So those are all lab values you can run if you suspect DIC. Um, and the patients are going to present with organ dysfunction. Their status might rapidly decline. And a lot of times these patients are already pretty sick to begin with. Again, they're in sepsis, they're in shock, they're a victim of a major trauma. So you do need to watch them closely. Um, so you can see new signs of organ dysfunction, I think rapid onset, like respiratory deterioration, kidney deterioration, etc. And then also signs of bleeding as well. The treatment here is to treat underlying disease, as always. And you can give heparin to interrupt clot formation, which will help increase organ function. Um, it just all gets tricky because you're bleeding as well. But that's a potential treatment option there. True or false? ITP can be treated with platelet transfusions. My clinical group is blowing up my phone. We have a paper due tomorrow. Yeah, that is B. That is false. Platelet transfusions would be great for just thrombocytopenia or platelet defects, but not quite ITP. Okay, heparin. Heparin is the anticoagulant common drug of choice. It works great by inhibiting coagulation, and it can help prevent further clot formation in patients with a DVT or pulmonary embolism. It is the safest drug during pregnancy, and its number one adverse effect is bleeding. That's the main one with a lot of these. Um, I would know that APTT is the lab value used to regulate dosing. It'll let you know if your heparin is therapeutic, subtherapeutic, etc. And if there's an antidote, which there is for a lot of these, definitely know it. Know all the antidotes always. Not only for this exam, but just for practice, you should know these. The antidote for heparin overdose or bleeding related to heparin administration is protamine sulfate. Um, LMWH is low. I'm so sorry, guys. I'm gonna cough. Okay, I'm so sorry, guys. Wow. Um, LMWH is low molecular weight heparin. It's a synthetic heparin. And the main one is enoxaparin. I'm pretty sure the brand name for that is Lovenox. Those are those like most of the time they're like pre-filled syringes. They're kind of cool because they like click, you know? Maybe some of you guys have given them in clinical. Low molecular weight heparin is not interchangeable with heparin. These are separate orders, separate prescriptions. And this is sometimes preferred because it is less likely to cause thrombocytopenia. So you will still have a healthy platelet count with low molecular weight heparin. And it is the drug of choice for DVTs specifically in the post-operative preventative setting. Um, a lot of your post-op patients are bedbound for a while. They're going to have those SCDs on, and you're just trying to prevent DVTs. So enoxaparin is a good option for that. Vitamin K antagonist. This is warfarin. Vitamin K is required for the construction of clotting factors in your liver. So by inhibiting vitamin K, you're not going to be synthesizing those factors as effectively. Warfarin has a major drug interaction with aspirin and NSAIDs, so you need to make sure that that's taken care of. Adverse effect again is bleeding. Important to know that warfarin has a narrow therapeutic window for benefits. So for your inpatient population, you're going to be checking that INR, which will tell you the therapeutic level of the warfarin pretty regularly to make sure that you're within that therapeutic window. Um, if your patient is stable, you can monitor that INR every 2 to 4 weeks. That is not how you spell stable. I'm sorry. And again, if they're unstable or in the hospital, it'll be a lot more often, especially if you're trying to figure out effective dosing. And because warfarin is a vitamin K antagonist, the antidote for warfarin is vitamin K. The factor XA inhibitor, the prototype is rivaroxaban. I feel like I've heard of apixaban more. That's just another one. It is an alternative to warfarin, and the benefit here is that it doesn't require close monitoring like warfarin does. Its therapeutic window is a little bit bigger, a little bit safer. And the antidote for this one is indexanet alpha. So that's kind of a fun name, kind of a unique one. Aspirin is an antiplatelet. It works by inhibiting platelet aggregation. Again, that effect on the inhibition of platelet aggregation can last for about a week to 10 days after a dose. Um, and you can develop salicylism, which would be aspirin toxicity. And signs of that are tinnitus and hyperventilation. I would know that. Again, if there's an overdose, an antidote, anything like that, I would recommend knowing that for the exam. ADP blockers, this is another antiplatelet, and the prototype is clopidogrel. We talk about this one in Patho 1 when we're talking about TIAs and strokes. This one works by altering the plasma membrane of the platelets, so these platelets can no longer recognize aggregation signals. In comparison to aspirin, it is a little bit slower to take effect, um, but it does still have kind of that lingering ability where after you stop taking it, you can still see those effects. So you need to teach your patient to discontinue the drug at least 5 days before any kind of surgical procedure, whether it's dental or medical, to prevent that risk for bleeding. This is one that we talk about a lot in Patho 1 and in Adult 3. Um, Tenecteplase is the preferred thrombolytic. It works by destroying existing clots. Um, it is used once a clot is confirmed in acute MI, so heart attack, pulmonary embolism, stroke, DVT, etc. So usually via Doppler, MRI, whatever it is, you know you have a destructive clot. The goal with tenecteplase or thrombolytics in general is to restore blood flow to that specific area that's being blocked by a clot. It needs to be administered within the first 4 hours of clot formation to be the most effective, and it has a very, very, very narrow safety margin. It can cause bleeding pretty seriously, so you need to first stop the infusion. That is the answer. If you get asked what you do first, if the patient shows signs of bleeding, you stop that infusion. Again, it can cause bleeding, hemorrhage, or arrhythmias. You stop that infusion if bleeding occurs, and you administer the antidote for tenecteplase, which is aminocaproic acid. I think I ask all the antidotes. I can't even lie. What is the antidote for heparin? That one's going to be C, protamine sulfate. What value is mainly used to regulate heparin dosing? Hold on. Yep, that one is D. What is the antidote for warfarin? Sorry, I know these are all pretty easy, but you do need to know these. Yeah, that'll be vitamin K. When is tenecteplase most effective? Perfect. That will be C. Good job. Okay, so don't leave yet. I mean, unless you want to, I can't hold you. Um, I'm throwing this up again because I did have some people join later. If you haven't done this yet, please go ahead and do it. That is what I have on the new content for you guys. That is what the bulk of the exam is. So I would spend more effort, more time on that specific material. If you remember from Patho 1, it's a very similar setup, I would say. So yes, definitely focus on those. Use the blueprint to your advantage. But what I have for you guys this semester is a cumulative slideshow. It's only about 40 slides, which, for example, the one we just did was like 100. So this one is nowhere near as long. Um, I would say maybe 30 minutes. Sorry, I'm trying to figure out how to do this. Okay. Um, I have a question. My slides did not have carboplatin or dacarbazine. I was wondering where the drug information. Okay, I can look at that afterwards so I can have a better answer for you. I think it was on the blueprint, but I can go back and find that for you because I'm not entirely sure off the top of my head. Will I be sending? Yeah, no problem. Will I be sending both PowerPoints? Yes, you guys will have access to both of these through your email. They'll both be on YouTube. I'm recording this as like one major session as well. Um, Difference with this slideshow, we'll talk about in a second. I do not have practice questions. That was funny. Sorry. In this one, we're just going to kind of go through that major material, really kind of drill those most important components from the last 4 months home. Tips for the final. You guys are about a week out. At this point, you've done nursing school finals before. You know what to expect. You know what they look like. Studying 16 weeks of material the night before, as much as I love all of my procrastinators, it's not going to work. It's not going to work the way you need it to work. I recommend studying a unit at a time, and really just breaking it up. I'm super guilty of sitting down and freaking out and trying to study the entire course, and it just never goes well. I have to take a minute, pick a topic, and just focus on that. Use the blueprint. I, yeah, just use the blueprint. Your professors made it for a reason. Focus heavily on that new material. And if you like the way that I do these sessions, you have access to all my videos on YouTube, so you can just use stuff I've done in the past. I do just have to say this because I got a lot of emails last semester. Um, I don't talk to your professors. I don't see your exam. I literally know nothing about your final. All I have is what you have. I have your course material, I have your blueprint, and I have my recollection. That's really it. So this is not all inclusive. I don't know what's on the exam. You still should study content not included in this session. I just have to say that. But we're going to go ahead and get started with the cumulative review. And again, this is stuff explicitly off of the blueprint in summary. Each unit, I want to say, has anywhere from like 2 to like 6 slides on it, so it's not crazy. So to get started, we're going to talk about stress from Unit 1. Stress can either be adaptive or maladaptive. Stress can be good, stress can be bad. We see issues arise when we have prolonged periods of stress, that high cortisol levels, inappropriate responses to stress, and all those things can cause disease, essentially. People who have chronic stress are at risk for infections, autoimmune conditions, hypertension, mental health conditions, kidney damage, and so much more. And I love saying that as if I am not myself a chronically stressed person, but we're in nursing school, so we probably all are. Inflammation as well can be acute or chronic. Stressors can be acute or chronic. Anything can be. The most important thing to know is that acute inflammation is protective. It serves a purpose, and your body will return to normal once that purpose is served. Chronic inflammation, though, is not protective. It kind of develops over time and actually causes damage, and it will create scar tissue. So that specific inflammatory response will not allow parts of the body to return to normal functioning. With neuro, your autonomic nervous system is divided into your sympathetic and your parasympathetic. Your sympathetic nervous system, your SNS, is the one that is activated in fight or flight. It readies the body for a response. So it's going to do things like shunt your blood to your vital organs. So you're going to see an increase in your heart rate, an increase in your blood pressure, and the neurotransmitter involved is norepinephrine. And opposite, your PSNS is responsible for rest and digest states. So it's going to activate in non-stressful situations. I'm mad chilling right now, so my PSNS is active. My heart rate and blood pressure are lower, and blood is going to be shunted to digestion and urinary. So those non-immediately life essential parts. And this involves the neurotransmitter acetylcholine. For neurodrugs, we have four classes we're going to talk about. We have adrenergic drugs, and these work, I'm so sorry, guys. I'm already doing so much better than I did last night. Last night was bad. Um, Adrenergics promote norepinephrine. They promote the action of the SNS. So they're going to induce fight or flight. So they can be used in emergency. It's an emergency use primarily for cases like shock or anaphylaxis, where you need to raise that heart rate, raise that pressure, open up the airways. The adverse effects here of epinephrine would be hypertension. You upped everything a little bit too high, or overstimulation of the nervous system. If you administer norepi, which is Levophed, they're at a risk for cardiac arrhythmias and an increased oxygen demand, which we know can put pressure on the heart and the body as well. Anti-adrenergics, well, anti-adrenergics do the opposite. They actively inhibit the SNS. In turn, they're going to be promoting the effects of the PSNS, so promoting rest and digest, and inhibiting that fight or flight type response. Prazosin is the prototype. It is used for hypertension, so it's going to bring blood pressure down. And its adverse effect is the first dose effect or that onset of orthostatic hypotension after administration. Atenolol is another antiadrenergic. It's a beta blocker, used, yeah, sorry, I said that. Beta blockers, if they end in olol, their adverse effects are bradycardia and bronchospasm. Four Bs. Beta blocker, bradycardia, bronchospasm. And with all beta blockers, you cannot stop them abruptly. That is a major do not do that. On the other side of things, we have cholinergics and anticholinergics. Your cholinergics will stimulate the PSNS or promote rest and digest. They're going to promote acetylcholine. So, you think PSNS, okay, blood's going to digestion and urinary. That's going to help treat a slow digestive tract and slow urinary tract. So paralytic ileus, urinary retention, also myasthenia gravis. Some other cholinergics are neostigmine, pyridostigmine, and bethanechol I would recommend reviewing. The adverse effects here are super similar to the adverse effects of your anti-adrenergics because anti-adrenergics and cholinergics have a very similar effect on the body. So you're looking at bronchoconstriction and bradycardia. And if a patient has a cholinergic OD, that antidote is atropine, which is an anticholinergic. So again, all these like opposites, it all makes sense when you start to put those pieces together again, because I know it's been a while for you guys. Anticholinergics work to inhibit the PSNS, so they promote that action of the SNS inherently. Atropine, which is the antidote for a cholinergic overdose, is the prototype and it treats bradycardia and bronchoconstriction. So it's going to raise that heart rate, allow the bronchioles to dilate. Other anticholinergics include scopolamine, ipratropium, oxybutynin, and benztropine mesylate. OD syndrome is the overdose of an anticholinergic. So you can see, again, overstimulation of fight or flight. So you can get a high heart rate. You can get high temperatures. You can slow digestion down so much you get a paralytic ileus. You can induce seizures or coma as well. The treatment for an anticholinergic overdose is physostigmine as well as activated charcoal. These are the four neuromuscular, neurodegenerative conditions that you need to know for the final. ALS, rip Eric Dane, literally so sad, is amyotrophic lateral sclerosis, something like that. It is the progressive loss of motor neurons that control muscles. It develops slowly and progressively. A lot of people start, maybe losing grip strength, and then control of their legs, and eventually it does progress to their ability to breathe, those smooth muscles like the diaphragm. And that is usually what ends up being fatal. For ALS, there is no cure yet. So treatment is supportive. You're really working on maintaining quality of life for as long as you can. Multiple sclerosis, or MS, is the loss of myelin on nerve fibers impacting the CNS, I'm sorry, or the central nervous system. There's also no cure for MS, but there are drugs to help reduce frequency and duration of relapses. That's the goal of those drugs. Signs and symptoms include fatigue, pain, weakness, and impaired balance and coordination. MS is a little different because instead of being like a steep decline like ALS, you can go through pretty intense periods of exacerbation and illness, and then periods of remission as well, or just like improved, lessened symptoms. MG, or myasthenia gravis, is an autoimmune condition that involves the destruction of acetylcholine receptor sites, also resulting in decreased muscle activity. Myasthenia gravis can have a crisis kind of mode, a serious exacerbation of it that's characterized by severe weakness and more dangerously respiratory weakness. So again, if we're talking about the muscles in your lungs, you might not be able to breathe, and there's a chance that you'll need to be ventilated. So that can get pretty serious during those crises. GBS is the last one. It is the demyelation of peripheral nerves, most commonly precipitated by an illness a few weeks before. This one is a little different because there is a high recovery rate. 80 to 90% do recover within a year of diagnostic. But during that time, you do really focus on supportive care. It presents with rapidly progressing ascending limb weakness, so bottom to top, and a loss of tendon reflexes. In this first unit as well, you have the cardiac content. This unit's it's pretty content heavy, I can't lie. Doing all of neuro and cardiac in a unit is a lot. You need to fully understand the difference between ischemia and infarction. Ischemia occurs when a vessel is partially occluded, so there is limited blood flow or temporarily halted blood flow. And it is reversible. That opens up, oxygen and blood's restored. You can get away without permanent damage from ischemia. Whereas an infarction, we're going to think myocardial infarction, like a heart attack, the vessel is completely occluded. So no blood, no oxygen, no nutrients are getting through. You can have permanent damage. And pain from an infarction is not going to be relieved by rest or certain medications like pain from ischemia might be. Angina is essentially chest pain related to inadequate blood flow to the heart specifically. So it's basically ischemia of the heart. The demand for oxygen by the heart is greater than the supply. You can have substernal chest pain that radiates, as well as nausea, vomiting, dizziness, and shortness of breath. So a lot of these symptoms do mirror the symptoms of a myocardial infarction. Stable angina is predictable, it occurs with activity, and it's very quickly relieved by rest or nitroglycerin. Whereas unstable angina, super unpredictable. There aren't any set in stone triggers. It can be more severe, more frequent, and it might not be relieved by rest or nitro, which again could be concerning for a potential heart attack. Which brings us to heart attacks. They present with a sudden onset chest pain that is not going to be relieved by rest or medication like nitroglycerin, no matter how many times you try. The symptoms are there for you. Myocardial infarctions can be STEMIs or NSTEMIs. If there's an ST elevation in the ECG, that typically is indicative of a more severe heart attack. If a patient has a normal ECG, but their lab results indicate an MI like troponin, that would be diagnostic for an NSTEMI. These are typically less severe, still heart attacks nonetheless. Those labs that you need to be checking include troponin, that's CKMB, and myoglobulin as well. Nitroglycerin is probably the biggest med to know here. It can be given short acting, long acting, it can be sublingual, it can be IV. It is going to help control chest pain with angina. It causes some pretty severe headaches, and it can also lower the blood pressure and the heart rate to the point of syncope. Um, so that's a big one. If your patient's hypotensive, you might not be able to administer nitro. Um, because of that, you do need to check the vital signs before administration. And if a patient is prescribed nitro because they have recurring angina, you need to teach them that if they take three nitroglycerin 5 minutes apart without relief, so we're talking over a 15-minute time span, they need to get to the ER because they could potentially be having an infarction. Beta blockers, you have atenolol, metoprolol, and propanolol, all those LOLs. Again, used for chest pain, used for heart attacks. If it's used for a heart attack, you do need to start within 24 hours of that MI. Again, all beta blockers, you cannot stop abruptly, and they all have that side effect of bronchospasm and bradycardia. These beta blockers can also mask symptoms of hypoglycemia. So in your diabetic patients especially, you're going to want to be checking sugars. And with all beta blockers, you need to check vital signs before administration. So you need to hold that medication if their heart rate is less than 60 or if their systolic pressure is less than 90, because again, it will lower everything and you don't want to bottom out their pressures or their heart rate. Nifedipine is a calcium channel blocker. It's used for angina and hypertension. Again, if it does its job a little bit too well, you can have hypotension, which would produce dizziness, potential headaches, and GI issues as well. Adjuvant medications for these cardiac issues include ranolazine, ACE inhibitors, aspirin, clopidogrel, and tenecteplase, which we talked about the bottom three there just now in the blood disorder content. And that's unit one. The thing I like about Patho is that I do feel like the blueprints are concise. I feel like it really breaks down what you need to focus on because there's just so much content for the course. So that was literally everything off the blueprint for Unit 1. Unit 2 is GI. Think way back to this fun one. A few conditions we're going to talk about first. First is GERD. GERD is that gastric reflux, that burning in the chest. It's the most common disorder of the esophagus. Um, Essentially, the physiology there is that your esophagus is not meant to handle the acidity of your gastric contents. So if gastric contents reflux up into your esophagus, it's going to cause damage, irritation, and heartburn, which is that burning sensation. That's pretty much it on GERD. It's pretty straightforward. Peptic ulcer disease, or PUD, is most commonly caused by an H. pylori infection. Um, Also, if someone's using NSAIDs for an extended period of time for lots of different purposes, that can cause ulcers. That's why we always take our ibuprofen with food, right, guys? Clinical manifestations are going to be a burning, gnawing, or cramp-like pain that's going to present a little bit differently depending on where that ulcer is. If the ulcer is gastric, you're going to experience that pain immediately after eating when that food hits your stomach. If it's duodenal, you're going to experience that pain 2 to 3 hours after eating, and a lot of times duodenal ulcer pain is worse at night. Complications from PUD, you can have bleeding and perf. Those ulcers can go kaboom, which is a medical emergency because now you're going to be, bleeding, you're going to be releasing gastric content into your abdominal cavity, and it's a hot mess. Diverticulitis is the inflammation or infection of diverticula. Those are those little outpouchings in your intestines, caused frequently by food or stool accumulating in the diverticula. This will present with lower left quadrant pain, tenderness, and some bowel irregularity issues. And it also can cause peritonitis, that's that infection, abscesses, bleeding, all that sort of stuff. Best treatment is prevention. You're going to encourage high fiber, high fluid intake, and think about foods that would get stuck super easily. In those little outpouchings, things like nuts, popcorn, seeds, you're going to want to help your patient identify and eliminate those triggers from their diet. Pancreatitis is one of the more severe things we talk about. It's acute inflammation of the pancreas. Um, they're almost always related to alcohol abuse or gallstones. And it can range in severity. If it's, yeah, mild or severe. You can have severe pain, sudden severe pain after a meal, um, pain that's hard to localize, so they might not be able to say, oh, it hurts right there. It's just going to say everywhere. Rigid abdomen, jaundice. If they have bruising around their belly button, that's indicative of a severe case. But they could also have low blood pressure, cyanosis, and cold and clammy skin. Liver cirrhosis. This is end-stage liver disease where fibrous scar tissue replaces that functional liver tissue. So this scar tissue is not functional. It is literally just tissue that serves absolutely no purpose. Um, it constricts biliary flow, which can cause portal hypertension. Think way back. Something like portal hypertension can cause ascites, esophageal varices, all those not fun complications. Anything with the liver too, your patient's at risk for bleeding, poor clotting, thrombocytopenia, because again, the liver is responsible for the formation of a lot of those really important clotting factors. Hepatic encephalopathy is when the liver cannot detoxify the blood. So your liver, it's failing, it's injured, it's diseased, it's not detoxifying effectively, meaning that the ammonia in your bloodstream is staying there. It is staying there and it is rising. That causes mainly neuro symptoms. Think confusion, irritability, memory issues. A lot of the times they can present as psych patients. They can, be difficult to work with, or I don't like to use the word crazy, but I mean, that is what they kind of can present as. So you need to check those ammonia levels with some of those neuro symptoms. And then lastly, gallbladder disease. You can have cholecystitis, cholelithiasis, which is gallstones, and cholestasis. In general, when you're talking about the gallbladder, you're going to see pain in the right upper quadrant. That pain is kind of colicky. It's going to come and go, often precipitated by a fatty meal, because your gallbladder is trying to release bile to help digest the fats. But whatever disease state is going on is stopping that from happening, causing kind of contractures and pain. You're also going to see jaundice, dark urine, and gray stool. For the GI meds, you need to know the antacids. You have aluminum, magnesium, and calcium-based antacids, each of which have kind of their unique adverse effect. Most important, though, with antacids, you need to know that you give it 1 to 2 hours before or after other meds. So you're not going to throw antacids in with their 9 a.m. regular morning meds. Another big one is the PPIs, omeprazole and pantoprazole. That's Protonix is the brand name. It's a common first choice because it prevents the release of gastric acid. Um, Pantoprazole specifically can be given IV. And if you remember talking about this a few months ago, PPIs are often given in the hospital setting because you're at a higher risk for ulcers in stressful situations like being hospitalized. So we'll give PPIs as a preventative for ulcers and gastritis and GERD and those types of things. Lactulose is a medication for hepatic encephalopathy. So that is that excess ammonia related to the liver's inability to detox. It works by taking the ammonia from the bloodstream and binding it to stool, allowing your body to excrete the ammonia with bowel movements. If a patient's on lactulose, you want them to be having 2 to 3 soft stools a day. That's about a therapeutic assessment. Um, you need to monitor their potassium levels because lactulose does carry the risk of hypokalemia. You need to monitor dehydration status and those ammonia levels with blood draws. Spironolactone is our potassium-sparing diuretic. It is the drug of choice for ascites, and just know the patient's at a risk for hyperkalemia with a drug like spironolactone. Perfect. That takes us to Unit 3, fluids, electrolytes, and acid-base imbalances. which is not the favorite I've gathered. Not the favorite across the board. Hang on one second. Great. Every time I come back, I'm like bright red. Fluids. Wait, did I skip a page? Hold up. No, I didn't. Okay. Anyways, revisit isotonic and hypertonic fluid volume deficits. With isotonic, your sodium's going to be normal. There's not a fluid shift, and your treatment is focused on isotonic IV fluids. Hypertonic, the main difference is that there is a fluid shift. You're going to have high sodium and you're going to treat with hypotonic IVFs. You need to know that with hypertonic fluid volume deficit, they are at a risk for behavioral changes, and that is primarily related to the hypernatremia from that high sodium. With any kind of fluid volume deficit, you're going to see increased BUN, hemoglobin, hematocrit, and urine-specific gravity. And they're both going to present pretty similar with dehydration, tachycardia, hypotension, weak thready pulses, etc. Hypotonic fluid volume excess then, this is when you have an increased vascular volume. So you're retaining a lot of water, but not the solute. So your blood is dilute. That's the big thing to remember here. The diagnostics are the opposite. So you're going to see a low BUN, low hemoglobin hematocrit, low sodium, and urine-specific gravity. Just remember again that hemoglobin and hematocrit and sodium are lower in a volume excess, which sometimes feels counterintuitive, but it's because your blood is more dilute. You have less hemoglobin per ml of blood. So it's going to appear lower. Your symptoms are just think fluid volume overload. We talk about that a lot in nursing school. Weight gain, vein distension, that JVD, crackles in lungs, bounding pulse, and increased intracranial pressure. In early stages, specifically of increased ICP or hypervolemia, you can initiate a fluid restriction. Um, very carefully monitor the administration of hypertonic IVFs. And if it's progressing or later, you can do hypertonic IV fluids like 3% normal saline or mannitol. That's that osmotic diuretic to lower ICP. With any kind of fluid imbalance, but especially fluid volume excess, you need to be closely monitoring I's and O's, daily weights at the same time every day, and in the state of excess specifically, diuretics are a pretty common drug for administration. I would go over these again, the different types of fluids. I know they suck. I felt like I could never escape these. Isotonic fluids are primarily used for hydration without the shifts. So you have zero point 0.9 normal saline, lactated ringers, and initially D5W before it becomes hypotonic. Your hypertonic fluids are going to decrease cell edema. They're really great for increased intracranial pressure. And the examples are 3% normal saline and mannitol. And hypotonic is primarily used for hypernatremia and cell dehydration. And your examples are 0.45 normal saline and D5W after that initial isotonic phase. These are the diuretics you need to know. Your thiazide diuretic is hydrochlorothiazide. It is potassium losing, and there's a risk for hyperglycemia in your diabetic patients. So you need to be monitoring blood sugar with your thiazides. The biggest one that we probably know the best at this point is furosemide, that loop diuretic. It will drastically increase urine output. Its main adverse effect is hypokalemia. Huge, huge, huge point. It can really bottom out your potassium. So if a patient's on furosemide, we monitor closely, and often we give potassium supplements. I think they call it Chlorcon is one of the brand names of potassium. And again, if a patient's on digoxin, they're at a higher risk for digoxin toxicity if they're hypokalemic. So you need to monitor those drug risks as well. Spironolactone, we talked about, this is a potassium-sparing diuretic, so its main adverse effect is hyperkalemia. It is great for ascites again. And mannitol is that osmotic diuretic for increased ICP. You do just need to be careful with your congestive heart failure or pulmonary edema patients. That brings us to electrolytes, everyone's favorite. You do need to go back, revisit, and memorize these ranges. Um, per the blueprint, sodium, potassium, and calcium were the imbalances to focus on. So that's all we're going to cover today. Sodium is between 135 and 145. If someone is hyponatremic, they can be stuporous, lethargic, they can have generalized weakness, headaches, seizures, some neuro concerns. If they're severely hyponatremic, so less than 115, this is when it gets very dangerous. They can have increased intracranial pressure, um, which can cause extreme lethargy, confusion, seizures, and death. And that is treated with that hypertonic solution or 3% normal saline. On the other hand, you have hypernatremia over 145. A patient can present with extreme thirst, fever, again, lethargy, restlessness, some similar symptoms to a fluid volume decrease, because hypernatremia can just be from too much sodium, but commonly it's from too little fluid because now the blood is more dilute with that sodium. And it is treated um, opposite, it's treated with hypotonic fluids like 0.45 normal saline. Potassium, normal is 3.5 to 5. Hypokalemia is going to present with decreased muscle activity, arrhythmias, and EKG changes. That's a big one. Again, potassium, you need to think arrhythmias and ECGs and the heart. If it's severe, it can cause cardiac arrest. Um, when you give potassium, if a patient's hypokalemic, never, ever, ever push it. Never push potassium. That's what they do in lethal injections, okay? You're not trying to do that to your patient. Potassium also is painful as heck, okay? It hurts. So you're going to infuse it very slowly over several hours, likely with an analgesic. Hyperkalemia then is the opposite. But even with hyperkalemia, we're still looking at heart issues. We are still looking at muscle changes. We're still looking at arrhythmias and EKGs. That is the biggest takeaway with potassium. Some meds, you can do polystyrene sulfate. That works kind of like lactulose, and it's going to take that potassium and it's going to help you poop it out. Um, you can do calcium gluconate, um, which is for more severe hyperkalemia, and it can cause hypotension and bradycardia. And then also your loop diuretics like furosemide, because furosemide will waste that potassium and get rid of it for you. The last one is calcium. The normal range is about 8.5 to 10.2. Hypocalcemia, big things to note. Still ECG changes. Um, Tetany is a huge one that's unique, and mental status changes. You can give calcium gluconate. You just can't give it with zero point 0.9 normal saline. If the patient has mild hypocalcemia, you can work on increasing calcium in their diet, primarily alongside vitamin D supplements, because vitamin D is required for the absorption and digestion of calcium. Hypercalcemia, the patients who are at risk are going to be your highly immobile patients, especially those with serious broken bones or spinal cord injuries. Symptoms are thirst, polyuria, deep bone pain. They can still have those arrhythmias as well. And you can treat that with calcitonin. It's going to pull that calcium out of the blood, and then also phosphorus because phosphorus antagonizes the action of calcium. Acid base. Really, you guys just need to be able to interpret your ABGs again. Given ABGs, you need to know if it's that respiratory acidosis, alkalosis, or metabolic. I put the normal ranges there again just for your review. Just remember, you're looking for what matches. Look at the pH first, determine if that's high or low, and then figure out whether the carbon dioxide matches or the bicarbonate matches. If your pH is 7.3, great, you're acidotic. So then you're either looking for a high carbon dioxide or a low bicarbonate. If it's a high carbon dioxide, that is a respiratory cause. If it is a low bicarbonate, that is a metabolic cause. So just revisit some of those matching skills there. But that's probably the most important thing from the ABG content. I wouldn't freak yourself out too much with like all the signs and symptoms of all the different imbalances, um, but just having a general idea would probably be good. And this is the last unit. It is the most recent unit, so I'm hoping this one feels a little bit more like recent review, fresher in your mind. Yeah. Uh, Also, I do have to say, I never thought I was seeing this content again. I have to be so for real. I never thought I was seeing this again. You learn all of this again in adult three, and it comes back and whoops you pretty good. But anyways, diabetes insipidus is an ADH deficiency. ADH is antidiuretic hormone. So if you're low in antidiuretic hormone, you're going to have a lot of diuresis, the opposite. The most common cause is head trauma, TBIs. You're going to have large amounts of dilute urine, extreme thirst, and all your symptoms of dehydration. And the treatment is desmopressin. It replaces that ADH, but it does have a black box warning for severe hyponatremia, which we just talked about does put the patient at risk for seizures. SIADH is the opposite. It's the syndrome of inappropriate antidiuretic hormone. So it has excess ADH. So now you have way too much antidiuretic hormone. You're holding all of your fluid in, increased fluid volume. So you're not going to be peeing like you need to. You're going to have low urine output. Um, you're going to be hyponatremic because your blood is more dilute, and you're still going to present with excessive thirst. This is that comparison again that I think is a good slide for understanding these two. Hypothyroidism is most commonly caused by Hashimoto's disease. I want you to think low and slow metabolism. So everything is slowed down, slowed heart rate, slow blood pressure. That's what I remember it as, low and slow. Levothyroxine is a synthetic thyroid hormone. It's the drug of choice for hypothyroidism. Main adverse effect is it can do its job a little too well. It can produce signs and symptoms of hyperthyroidism. Mixed edema coma is the life-threatening kind of crisis from hypothyroidism that can develop into cardiovascular failure and shock. If a patient is experiencing mixed edema coma, you need to monitor their status, prepare for possible ventilation, passive rewarming because they're probably hypothermic, and a cautious use of fluids as well. Oh, I'm sorry. People are messaging me. I'm not seeing it. I remember them like a season. Oh, that's awesome. I'm sorry. That was sent over 10 minutes ago and I just never got the notification, but that's a good way to remember it. Tell your friends if you haven't. Um, Hyperthyroidism is the opposite. It is most commonly caused by Graves' disease. So now your metabolism is super high. We're high and we're fast. Um, Tremors, tachycardia, that exophthalmos, bulging eyes, increased metabolism, weight loss. The life-threatening crisis would be a thyroid storm. Um, in general, with hyperthyroidism, you could treat with radioactive iodine, which is that one that produces lifelong hypothyroidism, kind of just like takes out your entire thyroid. And then you can also do propranolol to control the cardiovascular effects of hyperthyroidism, or propylthiouracil, which will inhibit that hormone release. But again, some of those downsides, it takes a while to work. It has some more side effects and it requires close lab monitoring. Hypoparathyroidism. Biggest thing here is the fact that it causes low calcium. Think low parathormone, low calcium. So if you know the signs and symptoms of low calcium, like the tetany, the cardiac arrhythmias, the mental status changes, you've got this down. So really you're going to want to work on increasing that calcium level. In opposition, hyperparathyroidism is the overproduction of parathormone. So you're going to see increased calcium. So now we're going to look at the signs and symptoms of hypercalcemia, which again, heart arrhythmias, You can have some bone pain, all that good stuff. For treatment, you can remove the parathyroid. You can also work on increasing hydration and mobility for the patient. Um, if a patient does undergo a parathyroidectomy, you do need to monitor them in the postoperative state for tetany, um, because you've messed with their calcium levels so much, their body might have a hard time adapting to that. So you need to monitor for that pretty closely. Last, like, few slides, guys, hang in there with me. Um, Addison's disease, this is the insufficiency of your adrenal cortex hormones, so those steroids. So we're going to see increased excretion of a lot of these electrolytes and water. You are going to retain potassium. You're going to have poor cardiac output and hypoglycemia. The medications for Addison's disease are primarily steroids that kind of just replace those cortical insufficiencies. So you can have hydrocortisone, which will work by decreasing inflammation and promoting that sodium retention, since with Addison's disease, you're excreting kind of a lot of it. And fludrocortisone, which again will facilitate sodium retention and potassium excretion, does come with some more adverse effects like high sugars, low potassium, heart failure, hypertension, and ulcers as well. Cushing's disease, you have the oversecretion of glucocorticoids and androgens. Um, I like to think they're like a cushion because they typically present with obesity, moon face, they can have like a hump in their neck. Um, all the side effects of corticosteroids can present in Cushing's disease because they have excess steroids essentially in their body. Um, Ketoconazole is the medication for Cushing's. It inhibits enzymes needed for cortisol synthesis. Main adverse effect here is that it can cause liver tox. Again, I think this is a really great visual to help you guys differentiate these, just to revisit before that final exam. Oh, I lied. I forgot about the anemias, to be so for real. Iron deficiency anemia, pretty straightforward. Again, we talked about this last week, so I'm not going to go too crazy into depth on it. Um, Ferrous sulfate is a medication given PO for iron deficient anemia. Adverse effects there are nausea, dark stool, constipation, and teeth staining. But it can be liver toxic, so you do have to monitor those LFTs. And then iron dextran is a medication given IM or IV. Um, it is, yeah, its main adverse effects would be tachycardia and hypotension. Um, I would just know the difference in the routes between the two of those and revisit those adverse effects for ferrous sulfate as well. Aplastic anemia, we have pancytopenia because of decreased efficacy of bone marrow stem cells. So we need to think low red blood cells, low white blood cells, and low platelets. Because of that, neutropenia, erythropenia, and thrombocytopenia. Treatment there, epoetin alpha and filgrastim. We just talked about those again with the cancer slideshow. Just understanding epoetin alpha increases your red blood cells and filgrastim increases your white blood cells. Biggest thing to note, I think, for epoetin alpha is that there is a black box warning for an increased risk of thrombus if it is given when the hemoglobin is over 12. So that's a big one. Um, that doesn't make sense. I don't think this slide was supposed to be on here. We're just gonna skip this. Sorry. I'll take care of that before I send it out. Megaloblastic and macrocytic anemias. These are the anemias that involve folic acid deficiency and pernicious anemias. I would recall that pernicious anemia is caused by the absence of an intrinsic factor, which means that no B12 can be absorbed. So you need IM B12 replacements because oral replacements of B12 will not work. Same kind of symptoms as your other anemias, but the really unique one is the smooth and red tongue with these anemias. And then pernicious anemia can have a neurological side to it as well because B12 is important in your neurosystem as well. This is the last one. Sickle cell anemia. This is that hereditary disease where hemoglobin is sickled. It's got that abnormal shape, which makes it stick to cell walls. Um, yeah, in your blood vessels, causing ischemia. So they can have severe pain related to ischemia from sickle cell. Um, if they have a sickle cell crisis, pretty much it's just a severe ischemic episode because of sickle cell. You're going to give oxygen, opioids, IV hydration, warm compresses to promote vasodilation, and blood transfusions and supplements as well. And that takes us to the new content, which is the entire other slideshow. That was a lot, guys. That is everything I have for you guys. Thank you for a great year. It's been a lot of fun. If you have any questions at all, I'm happy to talk. Let's talk about the final. Let's talk about content. But otherwise, you guys are free to hop on off and major luck moving forward with nursing school, with studying.